everyone. Pleasure to be here today. And I'm going to start by asking everyone, raise your hand if you agree with the title. Glucocorticoid is the best, worst medication. Who agrees with that? Okay, I think most of us physicians and patients, we do agree with this statement. It's a great medication in the beginning to control inflammation, right? And it could be a lifesaver. But then on the long term, then we start facing the side effect and dealing with it, right? In the beginning and before, prior to using glucocorticoids, the mortality rate in ANCA-associated vasculitis patient was almost 90% over 2 years. With the introduction of glucocorticoids, the mortality rate and the survival rate improved. The survival rate improved, but still we remained with very poor quality of life. And then Dr. Fauci and Dr. Hoffman introduced the cyclophosphamide, which it did improve the remission rate. However, we were dealing with comorbidities and the side effect. But there is remaining question for all of us as a physician, how much is enough from glucocorticoids? Should we give 1,000? Should we give the pulse? Should we give 60, 1 milligram per kilogram? Should we give 40? For how long? Should we give it for just a month, 2 months, 3 months, 6 months, 18 months? And over the years from the induction trials in ANCA-associated vasculitis, different trials used different regimens. Some of them used glucocorticoids, steroid, or prednisone for 12 months, some of them for 6 months, some of them for 18 months. So they did use different regimen and different forms of steroid. But the largest trial in ANCA-associated vasculitis, the Pexivas Trial, looked at the reduced dose compared to the standard dose, where the standard dose patient group, they were on 5 milligrams between 20 to 50 weeks compared to the reduced dose where they were on 5 milligrams by week 15 and 16. So the reduced group did use almost 50% of the total glucocorticoid in the standard group. They looked at the outcome in terms of death and end-stage renal disease, and so far there was no difference between the reduced dose comparing to the standard dose. However, there was less infection in the reduced dose comparing to the standard dose. And we felt it's time for something new and it's time for change. And then we have the Advocate trial, and this is an international effort where we were looking at medication that probably does help in minimizing exposure to the glucocorticoids. This trial includes 300 patients with new or relapsing active ANCA-associated vasculitis. And if we look here in the test group, most of the patients, they were off glucocorticoids after 4 weeks of starting Avocopan. And Avocopan group, Avocopan was found to be non-inferior to the standard care and remission induction at 26 weeks, and statistically significant reduction in the steroid-related toxicity, significant improvement in the renal function, and rapid reduction in the proteinuria, and also significant improvement in the quality of life. And it's the same way in giant cell arteritis patient. We were trying to look for another medication that probably helps us in reducing and minimizing exposure to glucocorticoids. And the only FDA-approved medication is tocilizumab Actemra. And in the tocilizumab group, a lot of the patients, they were glucocorticoids-free remission for 9 months comparing to 3.9 months in placebo group. And of course, we have other medication. They are being looked at in a clinical trial, but they are not FDA approved. But it's almost the same purpose from this medication to look for something can help us in reducing glucocorticoids exposure. And in the same way for Takayasu or Arteritis as well for other forms of vascular disease in addition. And this is, of course, glucocorticoids has, I think, reported more than 100 adverse events in total. It may cause cataract, glaucoma, increased ocular pressure. It may cause acne, bruises, skin thinning, allergic reaction, neurological issues such as depression, mood disorder, insomnia, cardiovascular problems, so many other things. And how do we deal with the adverse events, such as, let's start with increased infection risk. Of course, we try to optimize vaccination. If necessary, we can do prophylactic antibiotic, and if indicated, we can do immunoglobulin supplements in hypoglobulinemia patients. We screen for hyperglycemia and diabetes by checking hemoglobin A1C and monitoring blood glucose very closely. For steroid myopathy, we encourage physical therapy, and we try to reduce glucocorticoid exposure as much as possible. For peptic ulcer disease, we try to ask our patient to take it with food and probably to use H2 blocker or protonics inhibitor. For weight gain, from the beginning, I tell my patient, hey, expect some weight gain, but some of this could be fluid retention. And how we deal with the fluid retention, we try to watch our sodium intake, wear compression stocking if possible, and watch our diet from the beginning, because it's gonna increase your diet, and after a few months, all of the fluid retention should go away, but if you gain true weight, then you need to exercise and you need to watch your diet again. For sleep disorder, we try to ask our patient to take all of the steroid in the morning and to ask their primary care for sleeping aids. For mood disorder, to see a psychiatrist and family, and of course, support therapy. And for osteoporosis, I try to obtain a bone density from the beginning and make sure they are on the right vitamin D and calcium supplement and treatment if necessary as well. And Dr. Villaforte will be talking about adrenal insufficiency and fatigue.
Okay, so let's see this one. All right, I think we need to put the slides up there. I can see them, but you can't. All right, so. In a very practical way, us physicians then believe when I say that. The day we start the steroids is the day we're asking ourselves, when can we stop it? When can we start reducing the dose? I think the primary goal that we want to achieve with all these clinical trials and looking at all the new drugs is, can we substitute? Can we treat without steroids? It's because we know of the effects of the toxicities, and that comes as the day we start the steroids, and it continues to happen throughout all the treatment. So the first question that, in a different perspective that was 20 years ago, is we are asking ourselves now, are they always necessary at the beginning of the therapy? The truth is, they're still necessary at the beginning because a lot of people present in a very severe way with severe disease. And these are medications. I think what's very particular about the steroids is that they work very fast to control inflammation. And that way they're saving lives in certain situations. So there's studies that show that steroids starts to work within hours. So that's a way to achieve a goal of starting control of disease very quickly as the other medications start to kick in. So the whole idea is, are there other medications that should be studied? And yes, the answer is yes, to try to have the same kind of effect very quickly, and that doesn't have the same side effects of the prednisone. So that's always the goal, and some of the studies, as mentioned by Dr. Yassin before, are hoping to do that. And we're getting there. And the question is, why? What's the purpose? In addition to control the medication, the disease very quickly, we're trying to put it in remission. Are the steroids doing that? Most of the time we learn that they don't do that alone. So we're not achieving that second goal in the majority of patients. Take GCA, giant cell arteritis, for example. One of the main things we learned from the GIACTA trial was not whether tocilizumab works or not, but actually we learned that we were doing very poorly with steroids. That more than half of the patients were relapsing while still on steroids. So it was not achieving the goal of controlling disease or achieving remission, but just to control that initial burden of inflammation. So we're not achieving our second goal with steroids alone. So once we start the steroids, we should be asking, when can we start to reduce the dose very quickly, hopefully? And most of the studies in our own experience is showing that we probably can use less and less in terms of dose and in terms of duration as well. And now with more available and the armament of all the medications. So when we start steroids, people start having side effects right away, right? There's a number of toxicities that are well known to be initial side effects, like can't sleep, some mood swings, and increased appetite. That happens pretty quick. And then the next side effects, the next set of it, weight gain, the moon phase starts to appear, more mood swings, and things continues to happen, and new side effects appears as they continue to take the steroids. And the late side effects is what we worry sometimes the most as physicians, as the osteoporosis, is there a permanent diabetic effect of the steroids. So all of this we should keep in mind as we go, because some of them continue and some new ones continue to appear. So there's no such a thing that there is a point in time that will become safe to use the steroids. It only gets worse. And we're aware of that. So the main modern way to approach any clinical trial is, can we do well without it altogether? That should be our goal now and in the future. One other thing to remember that we tend not to think of this way is that steroids are actually immunosuppressive too. So we're always using this way of saying, okay, in addition to the steroids, I'm going to start an immunosuppressive medication. Well, even if you don't start the second one, the steroids are enough to increase the risk of infections. They are suppressive of the immune system. So it's not just about the side effects that you feel immediately, but the risk of infections is a high risk and is there every day. So once someone is taking steroids and we decided to start the taper, there comes the question of how slow should it be? And a lot of factors play a role in that decision. Now, we should try to taper and start to taper as soon as possible. And the sooner we start, usually we're able to taper it faster. The longer someone is on steroids, the harder will be the taper. That's because of two things that are happening that I'm going to talk a little bit about that. One is the adrenal glands. Once you start steroids in a high dose, the adrenal glands immediately realize, oh, we don't need to make any steroids. They're being given more than we make every day, and they stop producing the natural steroids. And what happens is they atrophy, they shrink the adrenal glands. And that way, when you need steroids again, let's say you stop the prednisone, they're not ready to produce. And it may take up to a year for the adrenal glands to be able to produce steroids again. So we have to keep that in mind and start tapering as soon as possible. And when can we taper it faster? Well, in a lot of times without the vasculitis is if we have the conscience as a doctor to start immediately on day one the other treatments. So for the majority of the vasculitis or the majority of clinical situations, independent of the diagnosis, most people need another treatment. We already know that steroids alone rarely are used. So why wait? And I still see that sometimes in second opinion in clinic. People have been on steroids for a month and haven't started the final treatment yet, or whatever it's going to be their immunosuppressive therapy, like they call. So the look at this point is to start any other treatment at the same time so that we can hopefully very soon taper the steroids quickly while we wait for the other medication to work. And when can we taper it faster? So I think it depends a lot on the diagnosis, but it depends also on how severe the disease is and how soon we get to the treatment, to start the treatment. And which medications are we using? There are different purposes in each medication that we use to treat the vasculitis. The question of can we avoid it completely? I think we're getting there. I think that we're not quite there, but close. And a lot of people is benefiting, for example, from the latest trial that looked into that with the Avocopan. And so the whole idea of the Avocopan is that maybe we can use a lot less steroids and avoid all this incredible enormous list of side effects. So that's very exciting in terms of future, and that should open doors for us to invest more on that kind of knowledge. And I think that's so important. It's not just you guys, but we don't like the steroids as well. Let's make just a point about a little bit of, since most people are on steroids at some point, one of the problems is the taper, is one of the most important papers. So what are withdrawal symptoms and what is adrenal insufficiency? Let's make a distinction here because the symptoms are exactly the same. So one might ask, do I have adrenal insufficiency when they develop symptoms, or do I have just withdrawal symptoms? So withdrawal symptoms are, we call it when the symptoms, the adrenal is still working or has the potential to work. So it's not a true adrenal insufficiency. But for some reason, and we don't know exactly what causes it, the body feels like there is no adrenal gland. The axis of the production of the hormone is just not there. So symptoms of nausea, vomiting, dizziness, low appetite, severe fatigue, some muscle pains, joint pains are common with this withdrawal symptoms, are the exact same symptoms that people have with adrenal insufficiency. But true adrenal insufficiency, the adrenal gland won't kick in and start to produce steroids again. So it's almost like a potential permanent problem. And some people, thank God not a lot, will have to be on a low dose of replacement of steroids because their adrenal gland don't work again. So withdrawal symptoms, there is a period of time that happens, and we usually go with a slower taper, and we'll find that magic number to control the symptoms, and then we'll start from there to taper much slower, and hoping that the adrenal glands are going to kick in with a much slower taper. So that's not a true adrenal insufficiency. Now, adrenal insufficiency, once that's diagnosed, then most people will need replacement therapy. That adrenal glands won't be able to work again. So that's a significant problem that can happen from use of steroids long term. And again, that was mentioned before, monitor potential adverse events. That has to be done all the time. So one of the most obvious ways of doing that is the bone density test. But you can imagine how many people will come who have been on steroids for 2 years and never had a bone density test done, unfortunately. So I advise everybody to get a baseline at day one, whether they're going to be on steroids for a week or 4 weeks, or whether they're going to have it for months. It doesn't matter. Everyone needs a baseline, so we have something to compare in the future. We don't know the future. Some of the diseases are relapsing diseases, right? So whether if someone needs steroids 6 months from now or 2 years from now, if they don't have a baseline bone density test, they won't have anything to compare with in the future. So that's extremely important. The day one that we start someone on steroids is day one we are getting all our baseline tests that we will need to monitor for future side effects. And most of them late term. They're not that late. There's some studies showing that people start to lose bone within 6 weeks of starting high dose of steroids. That's very short. And there is a lot of studies showing that on the osteoporosis world, if you look at that literature. There's even avascular necrosis that happens with post-steroids, which is another problem that we haven't talked about yet, but I'll be happy to answer any questions about that. So post-steroids, it's just a quick thing about it. It's something that's not very well studied or determined. We don't have a lot of data to actually know whether it makes a difference to give someone 1,000 milligrams a day for 3 days or to just start them on 60 milligrams a day. And that's a huge different dose. And one pulse dose of steroids can, in some people, actually cause avascular necrosis, just one dose. So we have to be conscious and careful when we're making a decision about if to start, when to start steroids, what dose, and what way to give it. And I think with that, I'll open up for questions so that we'll be able to really address what you guys want to know more about it. So can adrenal gland function be tested before you get to 0 milligrams of prednisone? That's a great question, but the tests are they're not very good. The tests are not perfect, and so there's so much that can help. Most of the time I don't do it. Yes, someone can check their cortisol level and can do even a stimulation test. Ideally, the test should be done when they're off the steroids. It's more reliable. But again, we cannot predict whether this means the adrenal glands are not functioning. They're not functioning at that point in time when you do the test, but will they start again? So if the question was if the taper should be slower because of that, I think the taper should be slower at some point, depending on how long someone has been on the steroids, and not because of the test itself. So I don't find it very helpful when they are still on steroids. But once you're on zero steroids, if you'd like to test that, that's more reliable. Dr. Yassin. I'll select the easy ones for me and give the rest of it. Does prednisone result in elevated lipid profile? We didn't mention that, but that's a great question.
Absolutely. It's the same way as it does increase the risk for hypertension. It does increase the risk for hyperlipidemia. And it does also influence the fat distribution in the body. So a lot, the cushienoid looking is just like fat distribution in the upper extremities, in the trunk, and the abdomen, while the legs, they will lose the fat tissue from there. So absolutely, that's a great question, and it does increase the risk for them.
All right, so I'll take the next one. And I'll make it more general. It's a very specific one, but it's a good question. So someone asking about eligibility to be on Avocopan if they've been on steroids for a long period of time. From what I understand from the question, the reason to use the Avocopan here would be to just try to stop the steroids after 9 years. So that's not the indication of Avocopan. The thought about it is you're eligible at any time if you are having active disease or you meet all the criteria to be on the drug, independent of whether you're on steroids or not. So the use of Avocopan has a different indication other than taking you off the steroids. So if the question is about active disease on steroids, then yes, you might be eligible for Avocopan, not because of that reason. Am I making it clear? Okay. Does joint pain increase when you stop the prednisone?
Absolutely, yeah. A lot of the patients, they do have underlying osteoarthritis and just regular arthritis, and probably osteoarthritis does have a low grade of inflammatory component related to the pain. So when we are giving steroid to them, it does help in controlling the pain, and when they are becoming off the steroid completely, this pain is going to come to the surface again. And I tell that to my patient from the beginning. So I say, Tylenol is your friend here. It doesn't mean that you need to go back again on the steroid. It means that your osteoarthritis pain is back again just the same way it was prior to the steroid initiation. And you need to handle it with the Tylenol. Unless if we are talking about just like relapse of the inflammatory component of the arthritis related to the underlying vasculitis, that's completely a different story, right? And usually these patients, they will have joint swelling in addition to the pain. That's completely different kind of joint pain, all right?
Okay, next question. What percentage of people that have the adrenal glands not to return, something like that? And what's an example of a medicine if the adrenals no longer work? Well, we don't know the exact percentage in our literature, the rheumatology world. It's very low. It's less than 10%. However, the asthma literature, which is better on that way, because asthma patients use steroids all the time. And when they flare up, they're back on steroids. So that's actually more common in that population. But thank God it's not a very high number, but nobody can tell you an exact number, unfortunately. Why is that? Because you don't follow up long enough to know whether the adrenal glands are going to recover or not. So it's a very hard number to know. And it may take up to a year, like I said, for the adrenal glands to return. What an example of medicine if the adrenals no longer. So the only thing we can do is steroids, because that's what they make, and we need it. And we need steroids so that we're alive, right? Steroids are responsible for our heart rate, our blood pressure, our breathing, everything. And our adrenal glands probably make about 7.5 to 10 milligrams a day, depending on the amount of stress. It's not the same exactly kind of steroids as prednisone, but very similar. So most people who actually need it long-term because their adrenal glands no longer work, don't use prednisone, they use hydrocortisone to try to mimic and always follow the peak of the steroids, so sometimes they even split the dose. That's a whole different idea of the steroid use, not to treat anything, but to replace the amount that people are not making anymore.
I have a question here. What's considered a high dose? So 10 until 15 milligram usually is considered a low dose. Between 15, 20 to 40 is a moderate dose, and anything higher than 40 is considered a high dose of glucocorticoids. Of course, this definition varies between the trials. So each trial, they have their own definition, but in general, anything like 40 milligram per day is considered a high dose. And there is
in addition to that, any doses beyond 5 milligrams, you're at risk of side effects, right? They might not be a high dose, but it may happen.
Yeah, a lot of the patients, they gain weight on the 5, they have mood disorder, they cannot sleep, even on 5 milligram. I had one patient on 5 milligrams, she had suicidal ideation. I could not use anything for her. So patients, they are different in terms of responding to the medication. Even a lower dose may have potential adverse events on the long term and the short term as well. That's why in every patient, we attempt to stop the glucocorticoids completely if possible. But sometimes we cannot do that, and some of the patients, they need a very lower dose, but we try our best to find what is the lowest dose possible for them. Some of them 1, some of them 5, some of them 2, 3, some unfortunate 10, so.
For bone loss side effect, do supplements help calcium and vitamin D? Yes and no. Any doses beyond 5 milligrams, you start lose bone. So it's important to start from day 1 to take calcium and vitamin D. But I would say beyond that is necessary. Vitamin D and calcium do not increase bone mass. They are hoping and trying to decrease the amount of progression of bone loss. For bone mass treatment, you would need medications such as bisphosphonates, Prolia, and others like Forteo. So that's why it's so important to get a bone density test from day 1. You might need from day 1 additional medication other than just calcium and vitamin D, and you won't know that unless you get a bone density test. So yes, calcium and vitamin D is extremely important, but not necessarily enough.
Yeah, and I want to add to that, it's based on your score, right? Whether you have osteopenia or osteoporosis, and if you have osteopenia, it's based about your fracture risk for the next 10 years, right? So if someone has osteopenia, but their risk is not that high, then we may say just like vitamin D and calcium supplements, make sure they are within normal limit. And sometimes we say repeat a bone density in a year and you don't need medication if we are just tapering down the glucocorticoids. This is in contrast to someone who has osteopenia with very high fracture risk in the next 10 years. Then we may say, I think you will need medication. We are still on requiring a higher dose of glucocorticoids, and your score is high, so we are trying to just minimize the risk of bone loss as much as possible until at least we become off the glucocorticoids completely. And then sometimes we may probably consider taking you off medication and just repeating the bone density annual or like every 2 years. So many factors may play in that.
Do you have other questions there?
What do you consider is a long-term use?
Long-term use? That's
for me, anything more than 3
anything
weeks.
more than a month. Well, our hope is, I don't think we're there, to be honest. We're still relying a lot on steroids and a lot of vasculitis. Remember, there are many different types of vasculitis, and majority of them still have not achieved the goal of having something to substitute. However, we're learning how to use less steroids, hopefully. But long term is, after 4 weeks, things start to change in your body enough to be considered a concern. So in general, as a general rule, if you've been on steroids for 2 months, you will require a slow taper. So if that helps to give an idea, you can't just stop cold turkey. So that to me is already a long-term problem. Why do steroids cause fat redistribution and weight gain? That's a great question. I don't think anybody knows the exact answer. There's some basic science studies have looked into that. There are 2 aspects of it. One is that steroids increase the appetite tremendously, so you actually end up eating more. So there's a weight gain from that, but also there is a direct effect of steroids on the fatty tissue, the cells there. So that we don't understand very well and how that works. So it's the transport of molecules in and out of the cell that the steroid has some kind of influence.
Mm-hmm. Okay. There is a question about fatigue and steroid. If the steroids help avoiding fatigue, is there another solution to this? So there are so many factors to cause fatigue, and I think the first step is to identify what's causing this fatigue, right? Is it related to the vasculitis, because the vasculitis is not well controlled? Is it related to other things? A lot of the patients, because of the weight gain, again, they develop sleep apnea. A lot of them, they don't sleep well, so they will feel tired during the day. A lot of them, they develop throughout the course, fibromyalgia, which another reason to have fatigue. So many adrenal insufficiency, another reason to have fatigue. So I think the first step is to identify what's causing the fatigue in order to know how to treat it. If fatigue is part of active vasculitis, then steroid is going to be one of the options for treatment in addition to a second agent, but if it's not, then we have to look for another reason. When you said that we are getting closer to not needing steroid, is that because of the tocilizumab or something more?
Okay. I think we're getting closer just because we want to study that more. And that becomes one of the primary goals in research. And that's the first step to get closer to anything, is to actually act on it. So when we start to do research with that purpose, we're getting closer. And I don't think that years ago, and like 10 years ago, even though we worried about it, we were not so actively including that as a primary goal in research. So I think because we were learning, the first question to whether we can control vasculitis with steroids alone, and we needed a second agent at 20 years ago. So that was a different kind of problem we were facing. And now we learned so much that the primary goal now should be, okay, can we do it without steroids? And that should be a primary goal in all the studies from now on. Now, we're getting closer because we're actually doing that, right? And we've seen that in the Giacta trial and seen it in Advocate trial. So we are looking actively into that in clinical trials. And I think that we're taking the first steps in a successful way. So that's an optimistic view maybe, but I've been long enough doing this that I've seen a difference in clinical practice. So when I started taking care of patients with vasculitis in 2001, it was a whole different world in terms of steroids. We use a lot less, and we have a different mentality towards it. All right, thank you so much for being here.
Thank you so much.